My topic today is PXE and the eye, and I want to thank Sharon Terry for inviting me to speak at this. If you do have any questions later on and you want to attend a support group and you're not coming to the breakout session, try to catch me during lunch, or you can have my email address in your little handout, so feel free to call me. So let's do a little anatomy of the eye. This is the front of the eye, the lens when people get cataracts. I'll be speaking about the back of the eye, or where PXE affects the eye in the retina. And there's a small area of retina called the macula, and that's where the patients, that's where your fine detail vision comes from. If you have 1 million nerve fibers that comprise the optic nerve, about 500,000 of them come from this small area. That's how you get your detail vision from the macula. Again, this is the, looking for the arrow here, the optic nerve, and the center, we call it the center of the retina. The center of the eye would actually be the optic nerve, but the functional center of the eye is the macula, the center of which is called the fovea. And patients with PXE usually develop many ocular features, but the earliest sign is called peau d'orange, or an orange peel, a modeling of the, we said the pigment epithelium we used to call it, but it's really calcification of Bruch's membrane, which is important. You'll see in a moment, Bruch's membrane separates the retina from the underlying vascular layer, and sometimes there are cracks in Bruch's membrane, which we call NGH Streaks, and then through those streaks, blood vessels can grow. We call that choroidal neovascularization. Those blood vessels are abnormal. They tend to leak, they can bleed, and they can cause scarring and loss of central vision. Here's some examples of NGH streaks. You can see on the slide on your left that some of them are pigmented, or they can just look like little radiating cracks. It doesn't show so well. They're called angioid because this is a blood vessel, and these look similar to the blood vessels. Here's a patient who's had 2 laser treatments in the right eye, and there's a scar, but they've recurred, and they have an area here where there is leakage, and you can barely see the fluid, but you can see it is surrounded by some yellow crystals or lipid molecules. There's some deep hemorrhage in it. On your right, you see an indocyanine green angiogram. The optic nerve is dark. You can see these interlacing angioid streaks, the scar, the neovascularization, and the peau d'orange quite nicely in this study. About 20 years later, this patient has developed a large central scar, secondary to additional bleeding from that neovascularization. This was long before we had the anti-VEGF drugs. So how do we try to prevent PXE and complications of PXE? Number one, avoidance of smoking. This is one of the modifiable risk factors. You've heard about, risk factors for disease. Some of them are genetic. We can't change our genetics right now, but we are working on that. That was the research meeting the last 3 days. Where a balanced diet, Lionel just said we don't even recommend a reduced calcium diet anymore. A reduction in dairy products is advisable because some of these patients do get accelerated atherosclerosis. The Valsalva maneuver is when you bear down, whether it's at a bowel movement or weightlifting. We try to avoid that in case there are fragile vessels in the eye. We don't want to rupture those. And especially important is to avoid trauma to the eye, because even mild trauma to the eye can cause a hemorrhage if you have these angioid streaks and fragile blood vessels. So we recommend protective eyewear during contact or racket sports. Early detection of a problem is important because we do have treatments for leakage to prevent that bleeding and scarring. So we do try to detect patients who are at risk for vision loss, and anyone who's a relative of an affected individual, and we do have genetic testing today, should be examined, maybe have genetic testing so they could be educated about what symptoms to look for. we usually provide the patients and instruct them in the use of the AMSLA grid, and the reason for that is, as I told you before, we have the retina and the white part of the eye, the sclera. In between the retina and the sclera are normal blood vessels, but if they break through Fuchs membrane and grow underneath the retina, they tend to leak. And when they leak, the retina becomes swollen and elevated, and the patient experiences distortion of the vision or blurry vision. That's an early sign of an eye problem that requires evaluation and possible treatment. We ask patients to look at a grid, one eye at a time, perhaps once or twice a week, to look for any distortion or what we call medically metamorphopsia. So when we evaluate patients, in the office, we check their vision, of course. We show them the AMSLA grid. We dilate their pupils and look for signs of neovascularization, signs of choroidal neovascularization, which would include the blood, the lipid, or the fluid that I mentioned. And we take fundus photos, color photos, red-free photos, autofluorescence photos, and we do have tools like angiography to evaluate the patients. And a very important tool is optical coherence tomography that we've had the last few years. I'll show you examples of those. Here's a patient with NGH streaks, subtle NGH streaks, and peau d'orange. And you can see the peau d'orange much better in the red-free photograph. You can see NGH streaks in the autofluorescence photograph. And here's an indocyanine green photo that shows the streaks and the peau d'orange quite well. Fluorescein angiography can show the streaks, and these look like they're very wide streaks, but that's because they're actually surrounded by some loss of pigment or pigment atrophy, through which you can see the deeper vessels, the normal vessels, the choroidal vessels, which proves that the streaks are actually in the layer between the choroid and the retina. This patient also had neovascular complex in this region that was treated back in 1983. This is before we had anti-VEGF treatment, and it was treated with both the red and green laser, and the patient did quite well. He was a diplomat from Europe. This is the OCT machine. What it shows is a cross-section of the retina. You can see on the top, we see it's a black and white machine, but it's color-coded for ease of evaluation. So when you see a red or a white color, it shows that the retina is thickened, and it's thickened because there's fluid under the retina. This is the horizontal scan, and this would be the vertical scan displayed horizontally, showing the fluid underneath the retina. And we had different modalities to treat neovascularization. In the past, we used thermal laser to cauterize the fragile vessels. We used a cold laser, which was called photodynamic therapy, which did not leave a large scar. And sometimes that was supplemented with steroid injections. We sometimes did surgery to rotate the retina to eliminate the scarring. But all of these have been abandoned in the last 12 years. In June of 2006, ranibizumab or Lucentis was approved by the FDA. So we've used Avastin, which was approved a few months earlier, and Lucentis for the treatment of neovascularization. And some of these drugs, a newer drug, Eylea, is available, which can last a little longer, and that's ranibizumab. We talked about aflibercept is Eylea. And I think Novartis is in phase 3 trials with a drug that will last even longer, at least 12 weeks according to them. And we talk about low vision rehabilitation when we can't treat patients medically. But thanks to the advent of these anti-VEGF injections, we see fewer cases of loss of central vision. We're able to stabilize 90% of patients. We actually improve the vision in 30 to 40% of patients, and I'll show you a few examples. This is a patient who presented actually in July of 2006, a month after Lucentis was approved. She was in we did a phosphate binding trial, and she had just completed the trial, and I guess a year later she lost some vision, and it was a month after it was approved, and we tried it. You can see there's actually some fluid, maybe better in the next slide. You can see some blood in the black and white picture, and some fluid surrounding it. And she had 20/60 vision and had decreased a few lines. And after 3 injections of Lucentis, her vision returned to 20/25, where it's remained for the last 9 or 10 years. This is her ICG angiography, and this is her 9 years later with 20/25 vision. She actually has required multiple injections in both eyes. She resides in the Philadelphia area here, so I don't see her too often, but she did participate in the Magnesium Trial. This is a young lady who I followed since she was 21. 23 years later, she noted the onset of distortion in her vision. This is the right eye showing some circumferential, that is circular around the optic nerve angioid streaks. The left eye had some streaks and a little slate gray colored membrane, which shows up on the fluorescein angiogram. Her OCT showed this area of thickening, again color-coded with red and white. There is some fluid under the retina. We actually get a recording of the thickness of the center of the macula. It was 320 microns, which is about 1/3 of a millimeter. And then 1 month after injection, she returned to normal central thickness of 258 microns, no fluid, no edema. The medications work fantastically for early cases. So this is why you should be encouraged, and any of your relatives, to review the Amsler grid on a regular basis. Sometimes if you have good vision in both eyes and you don't cover one eye at a time, you don't notice a decreased vision or a distortion that's off-center, and it's very important to pick this up early. This is a patient that was in the Magnesium Trial. Mark's going to speak about that later, but I threw in this slide because she is one of the patients who did develop neovascularization. We found no difference in the treatment and placebo group. One patient in the placebo group did convert to neovascularization, as did someone in both the treatment and the placebo group each had one conversion. She had a little dot hemorrhage, and on the OCT you could see fluid on both the horizontal scan and just above center. She had a central scar. At age 16, she was in a judo competition and was punched in the eye. She had a hemorrhage and was hospitalized, and that is from mild trauma, or there wasn't so mild, that trauma, but she recovered 20/50, 20/60 vision after the blood went away, but there was a residual scar. And later on, after she continued in the trial, but we did treat her, and she did develop subretinal hemorrhage just below center. She had some additional bleeding up above. You can see she has some other features of PXE, including salmon spots and calcified drusen, other features that help us with the diagnosis. In March of 2017, her left eye did develop neovascularization. You see some hemorrhaging in the retina, and you see some thickening on the OCT, some fluid under the retina in the OCT, submacular fluid thickening, and 1 month after injection, you see all that fluid goes away. 4 years after treatment, she's had 24 injections in her right eye and 8 injections in her left eye, and she maintains 20/50 vision in the right, 20/25 in the left. She's doing quite well, and we hope to have even better treatments in the future. So we talked about prevention and improved pharmacologics already. We can answer some questions later about stem cell therapy that's under investigation. There are some trials going on in England in Moorfields Eye Hospital. Retinal pigment transplantation in the future. Gene therapy is around the corner. There's actually one drug already approved for retinitis pigmentosa type disease in the eye, a blinding disease for which there is some gene therapy approved. Magnesium supplements, Mark will talk about, and the research group spoke yesterday about inorganic pyrophosphate supplementation, another possible future treatment. Thank you for your attention.
Hi, can you hear me better? I'm wondering about the patient you were discussing who had trauma to her retina after the judo situation. Did she also receive injections in that eye with the scarring, and did that improve some of that situation? Because it had been my understanding that the injections were only for situations where there were bleeding or this vascularization and not for any treatment of scarring. So clarification there would help.
Thank you. So that young lady is actually from Philadelphia, and she's originally from Slovakia. She had the injury there. She was punched in the eye. She was hospitalized with a hemorrhage. That's when they diagnosed her PXE with a biopsy of her neck. So she had 20/50 vision from that injury with a scar. So that is 20/50 vision is not perfect, but that's vision worth preserving. So when she developed signs of leakage and bleeding, we did treat her aggressively. So yes, it does not get rid of the fibrotic scar. We think of that when someone has active neovascularization. I sometimes talk to them about it's a network of blood vessels. It's like a bush in springtime. And when we treat them with these agents, we get regression of the vascularity. So it becomes more like a bush in winter, loses its leaves, but it's still there. It can still become active again. So she gets treated maybe every 6 weeks. She actually did not need an injection on her last 2 visits. So we try to withhold whenever we can.
We're going to take one more question and then our break, and because we're getting signaled, they'll put the break away.
I'm just interested, have you seen anyone who's developed the drugs, like immunity to these drugs? I've been on Avastin for 6 years, Lucentis for 6 years, and now Eylea. And I have developed an immunity to each one, and my doctor says they're talking about that it's a genetic thing where you actually develop an immunity to these drugs, so they're not working.
Well, I don't know if it's an immunity. As I said, we stabilize 90% of people, not 100%. So sometimes when someone is not doing well with one of the drugs, we switch, as they did with you, and that usually works. But there is normal progression of, as we get older, sometimes people can develop pigment loss and loss of vision from other things, but I don't know if it's immunity. I don't know how to study whether it's immunity or just that the drug is not effective. I don't know what immunity means in that context, but we do see 10% breakthrough.
Yep. Okay. Thank you, Wayne.
Thank you.